Hit the subscribe button or visit us at auau.auanet.org.
Thank you, Kelly. I'm going to make sure my AV is working here. I think that imaging, of course, has a direct implication on the disease state known as M0 CRPC, but that disease state remains an important component of the management of men with castration resistance in the earliest form. And so we're going to discuss that. These are my disclosures, and these companies, some of them do make products in the prostate cancer space, and so I want to assure you that we will be talking about randomized clinical trials and evidence-based medicine throughout the discussion. And this is by way of background. We all are aware that prostate cancer is the most common cancer in men, about 250,000 cases. Dr. Borjan has done a nice review of biochemical recurrence in general, and unfortunately, despite our advanced treatments, we still have the second leading cause of cancer deaths in men. Over 34,000 deaths this year alone will be attributed to prostate cancer in the United States. Having some delay on my advancing. So why focus on non-metastatic disease? Well, one of the reasons is this is a window of opportunity, and that window may be closing quickly depending on the patient characteristics and the doubling time. There is certainly a lower tumor burden that may offer a more beneficial and durable response. We certainly see lots of examples in our castration-resistant space where when therapies were employed late in the game, we got a certain response, but a much better response when these treatments were moved up. And so we see that, for example, with use of enzalutamide when it was introduced initially post-docetaxel, but better response pre-docetaxel. We certainly saw this even with docetaxel chemotherapy, initially introduced just in the late stage CRPC, where about 3-month survival benefit, but when moved back into the metastatic space, we're seeing 12 to 18 months. So M1 is a deadly disease, and delaying the development of this is certainly a worthy cause. So there have been 3 of the FDA-approved novel second-generation anti-androgens that are available to us in the M0 space. And unlike, say, flutamide or even Casodex, these medications are much more potent and have at least 3 different mechanisms of action that prevent binding of the androgens to the androgen receptor. They inhibit the translocation of the androgen receptor into the nucleus and then interfere with binding at the DNA level. So much more potent and much more impactful in terms of the results. Having a little delay here on the advancement. We mentioned earlier the doubling times, and we know that doubling times predict the development of metastatic disease. And some of this data is derived from some earlier work looking at bone-targeted agents where patients were enrolled and had non-metastatic disease, but they logged their doubling times and found that when patients' doubling times are under 12 months or certainly under 10 months, there is a high rate of development of metastatic disease within the next 1 to 2 years. And so we know that PSA doubling time is certainly a biomarker for the development of advanced disease. So what about the guidelines for M0 prostate cancer? Go back one here. We know that in patients with this disease, serial PSA measurements are recommended, 3 to 6 month intervals, which will allow for the calculation of that doubling time. And then again, as Dr. Stratton pointed out, conventional conventional imaging, usually done at 12-month intervals in the absence of symptoms, is certainly appropriate. So that's what's displayed here in this slide. In terms of the guidelines, the clinicians should offer one of these three agents, apalutamide, darolutamide, or enzalutamide, with continuation of their ADT in non-metastatic CRP patients who are at high risk, and we'll get into that, for developing metastatic disease. And in the studies, which I'll show you, these doubling times of less than or equal to 10 months were used for inclusion of patients into the studies. On the other hand, clinicians may recommend observation and continued ADT in patients with slow doubling times greater than 10 months, for example. And certainly currently systemic chemotherapy or immunotherapy in this M0 space is not recommended. Waiting for my slide to advance here. So it was an unmet need up until about 2018. And when we would give this course, we would say, we really don't have anything to offer you if you have a rising PSA despite a castrate level of testosterone, until there was clearance by the FDA to kind of study this, and the Oncology Drug Advisory Committee came up with a brand new endpoint for our clinical trials. They felt that metastasis-free survival was a reasonable endpoint and certainly clinically meaningful to patients, and that set the stage for the trials that led to the FDA approval in this space for these three agents. So I'll go through the studies. The Spartan study was a study that looked at patients all these patients had M0 CRPC. All of these patients had doubling times of less than 10 months and less than or equal to 10 months, and they were randomized on a 2-to-1 randomization scheme, given apalutamide in this case versus placebo, and then the primary endpoint of metastasis-free survival was set. Always want to emphasize the rapid doubling time of these patients. On average here, the median was around 4 months. So these were not all patients in your practice with a rising PSA despite castration levels of testosterone, but those patients that are at certainly high risk for the development of that bad event, the development of metastatic disease. So these are the Kaplan-Meier curves that showed the metastasis-free survival. It zoomed past me. Apologize, I'm having some timing issues with the mouse, but this was a significant finding in the development of death or development of metastases by simply instituting an additional agent in patients in this M0 space. Of course, there are side effects to these medications, and given that these patients are having the side effects of their hormonal therapy but not experiencing symptoms related to their cancer, it's important that the adverse events and the safety profiles of these agents are very sound. And if my slides will advance here, I will show you that in general these agents were well tolerated. So there are a small number of patients with grade 3 toxicity in terms of some of the things that we commonly see, like fatigue and a small amount of imbalance and falls. Unique to this was the development of a rash. Some of the patients, about 5% of them, had to have an intervention, stop the therapy for a while due to the rash, but these were self-limited, and then most of them were able to go on and continue with their therapy, and a small amount of hypertension as well. So again, showing further some of the overall rates of dizziness, a low but rate of hypothyroidism. So in these patients on apalutamide, we do check their thyroid function tests at baseline and periodically to ensure that we don't have that side effect. The overall benefit here, again, the Kaplan-Meier curves were pretty dramatic, but it was a greater than 2 years of metastasis-free survival benefit, which led to the approval of the agent. And then subsequently, they did longer-term follow-up. So that was 2018, but this was then published in 2020 here. My slides will advance, and I'll show you that not only. So when we first gave these agents, people would say, well, you're just delaying the development of metastases, but you're really not impacting on their ultimate outcome. But we were able to show that there was an overall survival advantage in patients when treated initially with M0 disease. So the Aramis trial was a similarly designed study in the M0 state. Again, patients with non-metastatic but rapidly rising PSA doubling times, and they were randomized to darolutamide as compared to placebo in another 2-to-1 randomization. And what we found was the, again, significant improvement in metastasis-free survival with the early use of this therapy. Side effects are listed here too, and in the interest of time, I won't go through all of them, but again, these therapies were well tolerated. All of the 3 studies that were done in this space also had quality of life components to them, which were also had some advantages. So again, if you're treating patients that are not having symptoms, you can prevent or delay the development of some of the worsening symptoms, such as urinary symptomatology, it's to the advantage. So the familiarity with the side effect profile of all of these medications is important, but the bottom line is that severe, like grade 3-4 toxicities were exceedingly low with the use of this study and darolutamide, as well as with the others. This is some of that quality of life stuff that I was referring to. The development of bowel or urinary symptoms were significantly improved or delayed the appearance of some of those symptoms with the use of darolutamide as compared to placebo. This was the further follow-up of this study. So now we have maturation of the data. And again, not just metastasis-free survival, but overall survival benefit with the use of this. And then I'll finally show you the PROSPER study, which used enzalutamide as its agent, similarly designed patients with M0 disease. Again, PSA doubling times of less than 10 months, and compared that to placebo. The patients were looked at with the primary endpoint of metastasis-free survival. Notice the rapid doubling time, kind of the composition of these patients in the trials, less than 6 months in more than 2/3 of the patients. The side effect profiles, again, are listed here. Again, well tolerated and expected types of adverse events, but severe adverse events were relatively low in all 3 studies. Some hypertension, as you can see here. This is the similar Kaplan-Meier curves that you've seen with the other 2 studies, showing significant delay in the development of metastases and or death from prostate cancer in these patients. And then an updated follow-up again, coming forward with that overall survival advantage that was seen in the first 2 studies. So again, when we started on this journey, it was believed that metastasis-free survival would be a noble endpoint, but what we subsequently learned is that not only did it delay the development of these metastases, but it also led to the overall survival benefit. So these are some take-home messages. We now have 3 randomized clinical trials that demonstrate significant improvement, not only in metastasis-free, but now overall survival. And I believe that was a pre-test question. The FDA approval for these 3 agents is not restricted by the PSA doubling time. However, the guidelines felt that given the enrichment of these trials with patients with rapid doubling times, and that was where the true benefit was, that we should encourage use in those patients with PSA doubling times of less than 10 months. Overall, the therapy is well tolerated. The decision to initiate a treatment like this is a risk benefit with the patient, and of course, taking into context their overall health and comorbidities. And then we know the future direction of this is, what about these enhanced PET images and what that will do to this disease state? Certainly, I predict a kind of Will Rogers phenomenon. We'll be able to more clearly categorize patients who are truly M0, so they'll do even better. And then we'll also detect those very early small metastases, and then so they will become M1, if you will, and they'll also do better because we've detected them at a much earlier stage than we would normally have detected our traditional metastatic patients.